Right. Okay. All right. Thank you very much. So I'm Stephanie Wong. I'm one of the pediatric rheumatologists at BC Children's Hospital. I completed my thank you. I completed my training in Vancouver, and then I completed a 1-year fellowship in Lupus in Toronto at the Hospital of Sick Children. I want to thank the BC Lupus Society for giving me the opportunity to chat about childhood-onset lupus, one of my favorite diseases. So starting with an overview, so I will briefly talk about the differences in clinical features between childhood onset and adult onset lupus, touch on transition challenges, moving from pediatric to adult care, briefly reviewing some current pediatric lupus research and emerging therapies, touch on a little bit about CAR T cell therapy. I'll leave it to Dr. Reynolds to give a bit more detail surrounding that, and then the plan for a local disease registry here at Children's Hospital. So starting with the clinical differences, just with kind of a show of hands of those who are either diagnosed with lupus, have a family member or a friend of those were diagnosed in childhood, so under the age of 18. Okay, very good. So, you know, about 20%, 15 to 20% of patients with lupus will present in childhood. So some clinical differences. So children tend to present more aggressively with higher disease activity compared to their adult counterparts. There's a higher risk of having kidney or renal involvement. So generally, about 80% of patients who, if they're diagnosed in childhood, over the first 2 years of their diagnosis, if they're going to present with renal disease, it'll be during this time period. So we do have very close monitoring during closer to their diagnosis. Pediatrics tend to have more neuropsychiatric or brain disease involvement, as well as hematologic compared to adults. They tend to have more lung involvement, joint involvement, like arthritis. They more commonly have Raynaud's phenomenon, so the color change to their fingertips with temperature changes, and photosensitivity. So just thinking about if you were diagnosed in childhood, right, you'd have a higher cumulative kind of lifetime damage risk, exposure to these medications, kind of the unknown potential side effects with like growth and development, as well as the impact, which we can't ignore in terms of the psychosocial aspects of it. So, you know, a child that's now diagnosed, it's a very like abrupt change in their lifestyle, right? They're now coming to hospital, potentially needing admission to hospital, now taking medications, multiple medications throughout the day. So the pill burden is significant. And now they just feel different than their peers. So the mental health component is very important, especially for our adolescent patients. So looking at kind of damage accrual, so overall damage rates are kind of comparable between pediatric and adults, so a little bit higher for pediatrics, as you would kind of expect just with the longer duration of having the disease. So damage patterns, they're, as you would expect, so for pediatrics is more predominant renal damage, versus adults is kind of joint, cardiovascular, potentially developing diabetes. So key message, earlier disease doesn't necessarily mean worse long-term outcome, but then just potentially different organs that are involved. Okay, so now we'll transition to talk a little bit about moving from pediatric to adult care. So the definition of transition is the purposeful and planned process of moving from pediatric to adult services, beginning in adolescence and continuing on into early adulthood. So some of the challenges that we see, so up to 3/4 of youth experience a gap in their care. So meaning they miss the first couple visits with their adult rheumatologist, or potentially being lost to follow up completely. Depending on where you live, you may have inadequate access to adult rheumatology, specifically in like rural communities. You're not only losing your pediatrician potentially at this time, you're also now moving on to care with your family doctor, who may or may not be as familiar with your course and kind of experience supporting adolescents in this transition period. I think we're very spoiled at Children's Hospital. We have, it's almost like a one-stop shop for a lot of our patients. We have access to many allied health, so nursing, social worker, occupational therapy, physiotherapy. You come visit us, you can see everybody. Versus obviously you move to the adult side, depending on which clinic you attend, you're going to be making, potentially separate visits for all this. So missing school, missing work, potentially. And if the youth ends up taking, say, a gap year or working, their adults or their parent insurance may not cover some of these additional services as well. And then the lack of health data integration. So we have the information when you're on the pediatric side, the adult side, but there's not so much integration. So sometimes we feel a bit lost of like, what happened once we sent you over? Did you make it there? So we have that kind of missing piece. So potential solutions. So increasing the integration between pediatric and adult rheumatology care. So we do have a transition clinic based out of the Mary Pack Arthritis Center. It's called the YARD Clinic for young adults with rheumatic disease. So not just lupus patients, but those with arthritis and vasculitis. They're all welcome to attend this clinic. It is staffed with like both pediatric and adult rheumatologists. You do have access to nursing and social work as well. And we see them kind of upon graduation to about like 22. So again, but it is based out of Vancouver. So if you're outside of that, sometimes it's a bit difficult. Other solutions, so building kind of healthcare professional knowledge. So kind of uplifting the primary care physicians to hopefully gain some extra knowledge and get more comfortable, supporting the adolescents in this time period, leveraging digital health technology. So AI is here to stay. There's lots of apps and things that can help youth during this period. And then kind of embedding like flexibility between each model, because there's not a one size fit all for every patient, depending on your center, depending on your city, depending on your disease and your patient, right? You need to cater how much support you need and what type of support you need during this period, because everyone's needs are different. Okay, so just briefly, talking a little bit about pediatric lupus research and emerging therapies. So in terms of current therapy, so this should all look very familiar in terms of treatment that are readily available for our pediatric patients. So hydroxychloroquine, Plaquenil, sometimes we like to call it like vitamin H, vitamin P should be in the water because of all the benefits it has for our patients. Mycophenolate, tacrolimus, commonly used for lupus nephritis, azathioprine, methotrexate, skin, hematologic manifestations, and then stronger biologics, including rituximab and cyclophosphamide. So current kind of treatments under investigation, so belimumab or Benlysta, you can get it through intravenous or injection. It remains the only biological medication with a specific pediatric lupus indication, and is currently approved for patients with lupus and lupus nephritis for patients aged 5 and greater. And it showed like it has really good safety profile. Like prolonged kind of effects as well, be able to reduce your steroid need as well as improving your disease activity. We have had only one patient having access to this medication, and it was compassionate release from the drug company. So again, when it comes to pediatrics, majority of the medications are off-label. We do really need to advocate and beg pharmacare to kind of provide some of these really important drugs for our patients. But I think GSK, at least specifically for belimumab, has opened a patient support program for pediatric indication. So I'm actually trying to get one of our patients on it as well.
Can I ask a question?
Yes.
Yeah, regarding the biologics. So the inclusion criteria, especially for children, what are the specifics? Right? Because not everyone's going to be eligible. And then I do have a second question in terms of jurisdictions. Is that BC specific?
Yes. Okay. Yeah. So like it depends on like Health Canada. I think majority of these drugs that in the trials that have been completed, it's the youngest age is about 5 or 7. So it is hard.
Yeah.
And yeah, we just have had one patient versus like adults. I'm sure it's much more readily available, similar to anifrolumab or Saphnelo. It's been approved for adults for moderate to severe adult lupus. Kind of early case reports has shown dramatic improvement in refractory cutaneous involvement. We do have a clinical trial here at BC Children's called the Blossom study. However, we are not or we have not been able to recruit because they have very strict exclusion criteria. You're either not sick enough or too sick. So we end up not able to recruit. We've screened a few patients, but we have not been successful, although it's a very good drug as well. Obinutuzumab, it's also a B cell depleter similar to rituximab. It has a deeper B cell depletion. It has longer effects as well, but again, we do not have access to that in Canada. Dipirolizumab, Pegol. Similarly, we don't have any clinical trials at this time, and then telitacicept, which works similar to belimumab, but has an extra protein target and may provide further B cell depletion. Okay, so CAR T therapy. So we have the future, and that's not what a CAR T cell looks like. It's a nice graphic, but it's the closest to a cure that we have. So again, I'm going to leave it to Dr. Reynolds to go through more details surrounding CAR T, but kind of briefly, it's extracting your own blood and targeting your T cell, genetically modifying it. So then when we put it back into your body, it targets these more active B cells that we know is part of the pathophysiology in lupus. So in brief, first blood is removed, the T cells are removed, the process called leukapheresis. Once isolated, it's sent to a lab to be genetically modified. The patient then receives chemotherapy, and then it is infused back into the body, and then they stay in hospital for monitoring. And essentially, it's a potential kind of reset of the immune system. So removing these harmful B cells allowing the body to kind of rebuild, hopefully, the immune system from scratch. So some of the key kind of mixed age, so adult and kind of more young adult studies that have been published. So the first patients with lupus were treated with CAR T cells in Germany starting in 2021. All of them were able to go into remission, were able to stop their lupus medications, and then this has been replicated in multiple sites in China as well. So completed and published studies specifically with pediatric patients. So since then, approximately 22 patients of children with lupus have been treated with CAR T cells. Again, similarly, it's in Germany, Italy, and China. The European studies, 8 children, 4 of those with lupus, all showed substantial improvement. Were able to stop their medications for benefits lasting at least 16 months on average. The study in China, they had 15 children with lupus. 12 out of the 15 achieved major disease remission and improvement at 6 months. And then similarly, there are 3 teenagers also in China that also had were able to receive or achieve remission by 3 months. So the long-term effects, I think we're still waiting for. And I think, again, everyone wants a piece of the pie and everyone wants to be involved with this. But we're still waiting on in terms of like safety and that type of thing. So even locally, we're working with Alberta, so Calgary and Edmonton, trying to work towards like a local CAR T trial for children with severe autoimmune conditions. So not necessarily just lupus, but other rare conditions like juvenile dermatomyositis, systemic sclerosis. Those are all diseases that could benefit from CAR T, and collaborating with other centers as well. And then fortunately, there is a lab in Victoria, so very just our neighbors. There's a current site of manufacturing these CAR T vectors. Okay, so one of my goals and moving the ball forward a little bit. So I'm creating a local childhood onset lupus disease registry here. So at present, we're following 58 pediatric lupus patients at BC Children's Hospital. Approximately on average, we have about 8 to 12 newly diagnosed patients per year. Just in 2025, we had 5 new lupus nephritis patients, biopsy confirmed, that we are currently following. So why is a disease registry important? Right, so it essentially aggregates data on this rare kind of heterogeneous disease to hopefully improve treatment, long-term outcomes, supporting research that can't be done in individual studies. And there's a national push now amongst multiple sites or pediatric sites across Canada with plans on like a federated disease registry. So we're hoping to collect obviously the same data that can kind of match and to be able to merge these data sets to then be able to present and look at long-term outcomes. So I've obtained ethics approval here locally. I'm also including the yard clinics for those patients that end up transitioning there. I can talk a little bit more about that. We're building the REDCap database currently, and then we'll be collecting multiple patient-reported outcomes, including fatigue score, pain score, cognitive function, and routine mental health screening. So as I mentioned, so the yard clinic, this young adult with rheumatic diseases, it's right across from VGH, and because I also work there, I'm able to collect ongoing data for those pieces. Sorry, wrong way. Here we go. So take home points. So childhood onset lupus can be more severe and be more aggressive compared to adults on presentation. Transition from pediatric to adult care is a very important and vulnerable period of time. Emerging therapies in the works for treatment and CAR T cell therapy and the need for ongoing research. Another goal of mine is to create a specific transition clinic on the pediatric side. So having some of the adult rheumatologists come to our hospital, being able to provide like warm handover to these adult rheumatologists, having the patient have a face-to-face, have a familiar person to know where do I call, what's the address, like what time is my appointment, and working through some of these more transition specific issues to just provide autonomy and just comfort before we hand them over. So anyone that was diagnosed in childhood and have any input about what would be important for a transition or what you would like to see, please find me after the presentation. And I just want to say happy Mother's Day, folks, for the mothers, grandmothers, maternal figures. I know it's an important holiday over this weekend, so I appreciate people taking the time to come join us for the presentation. Thank you. Questions? Yes.
Is there a higher incidence of pediatric lupus?
No. I think at least for us, it could be like 2 to 34 out of 100,000 kids or people that present. So it's not more common than adults.
Oh, I didn't mean that. I meant over the years. Are you seeing more?
That's a good goal. Yeah, really good question. So what we actually found, at least for our center, is during COVID. So I don't know if COVID just activated the immune system in a different way. We did see actually a lot of lupus, more juvenile dermatomyositis compared to the average, but I think things have kind of leveled off now, I would say. And I would say the sex differences. So Dr. Miri had mentioned like 9 to 1, like more female predominance. In pediatrics, it's more like 5 to 1, and then it kind of transfers over. So still more rare in boys, but.
But that also could be because men don't necessarily go to doctors as frequently or talk about their symptoms. I mean,
I would say their parents probably do.
Yeah.
May not, yes,
Yeah.
yeah. And then I think because how lupus presents, it's kind of non-specific symptoms, right? So I think sometimes there'll always be a delay in diagnosis.
Yeah, so as much of the challenge, then again, right, the first line of care prior to a referral to a rheumatologist even.
Yes, yeah, so like leveraging, making sure our pediatricians and family care or family physicians are aware of this disease. I mean, I'm sure I can talk to any of the adult rheumatologists in the room, the number of like ANAs, like certain tests that are just sent out without specific questions. So just educating a little bit on what to look for and the signs is really important.
I have to just say, I'm overwhelmed with the number of drugs that are out there and that are being used. I mean, and it's because I don't like taking drugs. So when I see that whole list of drugs, I find it very overwhelming.
I mean, I think anyone from like the pediatric side would also say, I think as I kind of alluded, the pill burden is really hard for patients, especially you're taking a lot of prednisone in the beginning. There are times where, so the mycophenolate is a twice-a-day medication. So we commonly know maybe patients are taking it 50% of the time, right? So sometimes we do have to switch treatments based on the trouble, right? And the, adherence is very difficult. But we know that a lot of these drugs work, right? And the risk of ongoing disease, inflammation and activity and damage for long-term consequences to us kind of balances, hopefully getting things under control and then hopefully getting off, except the vitamin H, right? You want to keep the vitamin H on board. Thanks.
Thank you.